I'm not an expert. No, that was like a I still have
all of the habits and all of the driving down the road, really cool.
scientists that this is fun. Oh, it's like, don't dismiss them. So I try to listen.
And they don't see a ton of either.
Oh, are you really? Oh, okay, great. Yeah, you're out there with Josh and Sherry and
Oh, okay.
What is that?
Scissors cutting the genome. Yeah. So I think before you started,
supervisor took over the wall because they thought I was having
don't know what's needed. So we're I think, are you and I ready? Okay. So just send me the and it's an offer to me. I was just if someone wanted to right we could and we're big fans of patients. Patients to come work on and their own pace. So it's just a great opportunity.
Had to close the doors and go
and it's like
but it's just my brain. Well, no,
there's not. Well, I'm talking with them.
it's not great, but it's
So So this guy is named Eli Penn. He's actually just started, but he's done a few from training. Literally just had
That's what I got right now. When I said you were.
tonight. That'd be for day.
Yes, I mean here, but for me, well, I'm here, so do you- Like I just keep getting stronger with my there are days that
But it's, to me, it's for scientists. Even your
right, because she sent this.
So we have a big push. Follow on. Try to learn.
You know, it's just.
And then start to oh, I'm always
And not. Yeah, not religious to me, like, it's just like, yeah.
That's the hardest thing.
And so,
And it messes up my job. Like, I have issues with
Yeah, well, we hope to make a difference, and, when Courtney, you follow her, she's incredible. She's also very tough. She's hard on me.
because my family going off
And that's what's missing, not only in India, but in other areas of where I would never say anything else. Besides, I think it's probably
I don't think that is there.
yeah, and I think,
Because I think myself in this thing.
yeah. Well, when we did, so Courtney did it, there's a new NIH trying to, I think it was an annual, so we as scientists But right, it's underdiagnosed,
there's not a
My husband was a nurse.
But he's that same person. Were you the one that, did you say, because one of the teachers emailed me, that wasn't you. It was the same.
I'm going to give you guys a 2-minute warning, and then we're going to get started. I love that you're all talking and you're interacting, but we need to get started soon.
You too. They don't like, because they all of a sudden say, well, that's me for it. If some people there will ask for again, take them on. One is to mention that.
Test, 1, 2, 3, 1, 2, 3, 1, 2, 3.
Huh?
Do you have a job? I met you at the dinner in July, and I'm a nurse.
All right, guys, we're going to get started. So welcome to the Charleston chapter of the Bobby Jones Chiari Syringomyelia Foundation meeting. I'm so glad all of you came out tonight. We have a patient speaker tonight, and we have an expert lecture on shoulder instability. I also want to let you know there's a lot of research that the Bobby Jones Chiari Syringomyelia Foundation is doing. And if you're interested in finding out more about that, the people here, Kristen and Mary and Dorothy, they'd be glad to talk to you about that. We also have virtual support groups for adults, parents. We actually started a child's group for young children, and we have a young adults group for like high school into college age. So if you're not on the email list and you're interested in any of those, please let us know. We can get you on the email list, or you can at any time look on the Bobby Jones CSF website, and that has all the different events. They also have Ask the Expert twice a month, and they'll have a physician or whoever for the subject of the night answer questions and address different issues related to whatever that subject is. So there's a lot of support, a lot of resources if you check out the Bobby Jones CSF website and see what's available, and if there's anything that interests you. And of course, always, if you need to know anything more, you can always contact me or somebody at Bobby Jones. So we're going to get started with our patient journey. And Kayla Selden is good enough to volunteer. She's going to tell us about her journey with EDS and her shoulder issues too. So Kayla, thank you.
Hi, thank you. I just want to thank, I'm a little taller than you. I just want to thank Nancy for allowing me to have this opportunity, and Susan for thinking of me. I don't see her back here, but I know you all know Susan. Just take time to thank her, the work that she does for Ehlers-Danlos, and the time that she puts in is, I can't imagine. This is truly her passion, and just take time to thank her because she does sacrifice a lot for us. So I'm Kayla Selden. I'm really excited. When I first started getting really sick, my dad had bought me a little zebra stuffed animal. And the irony is not lost on me that 10 years in the future, that little get well soon gift would be the mascot for an illness that I struggled with my entire life. I, like many of you, waited half my lifetime to get diagnosed and to have the answers that I needed. As a child, I was always super flexible, super clumsy, but nothing seemed out of the ordinary. I had my party tricks like we all had. Especially in particular, I would take my foot and turn it around backwards and chase my little brother down the hall. He'd be like sobbing, like, put your foot back on right! But that didn't seem weird. It just seemed like something I could do. Nothing seemed out of the ordinary. My mom did have a few areas of concern, in particular when I would exercise or do something really active, I would start to breathe really heavy. My heart would race. I would start to turn purple, especially in my legs and my hands. But every time that she went to the doctors, they would test me for asthma, tell me I didn't have asthma, and then just say, oh, she's just growing, she's just small. And so that's what we thought. I'm just growing, I'm just small. And it wasn't until my senior year of high school that I began to get very, very sick. I was doing school online at this point, and I could not look at the computer screen without migraines and auras. I couldn't eat without throwing up. I was falling asleep all the time at weird times, and I began to pass out almost every single day. And so, of course, my parents were like, you have to go to the doctor, we're taking you to the doctor. And I was diagnosed with anxiety and being underweight, which I was. I was very underweight. I was 17, 18 years old at this time, 5'8", and 87 pounds. They told me that that put my BMI at 14. I was also told that the level of starvation is 15, and that at 13.5 you can start to experience organ damage. So, my parents did what any good parents would do, and they bought me Pediasure, and protein shakes, and broth, and beans, especially lentils. I still hate lentils. And they force-fed it down my throat every chance they could get. And my parents slept by my door at night because I had no energy to do anything. The only thing that I had energy to do was lay in bed. And for some of us who do not have chronic illness, that sounds super silly, like you don't need energy to lay in bed, but for those of us who understand, you know that low point where you get to the point where every ounce of energy in your body is being pulled together just to breathe and just to survive. So I was trying to survive, trying to drink this Pediasure, trying to keep myself alive, and it didn't work. Instead of 87 pounds, I now weighed 82. Putting my body mass index at 12.5. I began to lose my hair. 18 years old, losing my hair, big bald spots. I began to have issues with my menstrual cycle. I began to throw up more and more and pass out more and more, and I couldn't do anything. I was falling behind in school, and as we talked about, there aren't accommodations for people with chronic illness in school. It didn't matter that I was a straight A student prior. It didn't matter that I was involved in clubs. It didn't matter that I was expected to graduate early. All that mattered was that I was falling behind now. And so I stopped going. I just gave up. I was at the prime of my life. I was at the stage of my life where the world was my oyster, and I was expected to step out into the world and find my identity. And I felt like I was at the end of it. And so I prayed all the time. I begged and I begged and I asked God. I was in the middle of the desert and I asked God, I was like, please just give me a lake of water. Please just give me a lake of water. I'm so thirsty. Please give me a lake of water. And nothing came. And so I told myself, you know, if this is really anxiety and my mind is capable of making my body feel this awful, I'm just going to ignore it. And so that's what I did. I just ignored it. I stopped going to doctors, started taking anti-anxiety medicine, and I ignored it. Every time I had pain, just ignore it. Every time I had anxiety, which by the way I didn't have until I was told I had anxiety, anytime I had anxiety about my body and the fact that this was anxiety, I would just ignore it. And so that became my motto, ignore it. And through this, ignoring it, I pushed myself to get my GED. I pushed myself into college, and that is where I fell madly in love with art, and even madder in love with my husband right over there. We met at a college ministry, and he became one of my biggest supporters and advocates. But at this time, I was teaching and trying to be normal and trying to date this super hot guy and keep up with him, that my health was like, nope, you can't ignore me anymore. And I had my first partial seizure in 2017. From there, it was a constant downhill. I started dislocating my shoulder consistently. I dislocated my collarbone, I broke my ribs, got diagnosed with ulcerative colitis. Like, it was just everything you can think of all at once. It was like, whoop. And I began to pass out a lot. We got married in 2018, and we kind of had a heart-to-heart, and it became less about me choosing to ignore it and more about the fact that I can't ignore it anymore. I have a husband. We want a family. I can't choose to ignore it. And so we started trying to see doctors, and I was diagnosed with hypothyroidism and anemia, and at one point there was Lyme disease, and then my potassium was low, so it could have been hypokalemia and all sorts of things, but there were no answers, and I was still passing out, and I was still turning blue, and my heart still hurt every time I got out of bed. And so it wasn't until I saw Dr. Wharton in cardiology that he sat with me for over 2 hours and listened to every aspect of my story and every aspect of my family's story. At this point, hypermobility, flexibility, I didn't even realize that that was on the table, so I didn't mention that to him. But he diagnosed me with POTS, and I thought that that was it. That was my answer. I had POTS. And so I can handle that. It's chronic, but at least I can take my salt and I can wear my compression stockings and all that jazz. And so he also referred me to physical therapy for my shoulder because I had dislocated it so much that I had this huge muscle cramp. It was at physical therapy where I got some of my answers. If it wasn't for the first physical therapist I saw and her humility, I wouldn't be here. I wouldn't have understood what I had. She told me, she said, Kayla, you are insanely flexible. And I said, thank you, I know. And she goes, no. You are insanely flexible. I am hurting you with what I am doing. And she said, I can't see you anymore. Like, I am putting you in pain through what I know to do. And first of all, if you've ever had a doctor tell you that they can't see you anymore because they don't know, that, or a physical therapist or anybody, that's scary. But I am so glad that she had the humility to tell me that she couldn't do it. I am so glad that she had the strength to see past herself and to her patient and say that she can't do this. And so she referred me to Dr. Patel, where I had an upright MRI and I was formally diagnosed with EDS and CCI with cervical myelopathy. From there, I was referred to Susan, who has been my biggest tool in my Ehlers-Danlos journey so far. I know almost all of you, or probably all of you, see Susan and you know how important it is. She's probably sitting there thinking that I'm not standing correctly, but I'm sorry, I can't stand and talk at the same time. Maybe one day I'll get there, but we're not there right now.
We need to practice it.
Yeah, we need to practice. I'm trying to lean into the mic, I'm sorry. I'm not as short as Nancy. But and then I had shoulder surgery with Dr. Eichinger in February to make sure that my shoulder didn't dislocate anymore. And I can gladly say that it feels way more stable now. So in those times when I prayed for that lake of water, and God didn't give me that lake, I'm going to continue praying for that lake because I do believe that that day will come. But instead of a lake, he gave me an empty water bottle, and he introduced me to people with access to water. And so what do? I take my little empty water bottle, and I go to Dr. Eichinger, and I fill it up with his wisdom and knowledge. And I go to Susan, and I fill it up with her compassion and her just sheer understanding of this and her empathy. And I take that water bottle, and I go to you, and I fill yours up with empathy, and I fill yours up with empathy. And that's what this is about. Like, when I asked for that lake, God gave me the lake. You guys are the lake. You guys are the lake. We're the lake. And so before I finish talking, and Dr. Eichinger comes up and fills up our water bottles with his wisdom and knowledge, I just wanted to say something that I learned about zebras. And when a zebra is injured, the fellow zebras their dazzle will form a group around the injured one. And the injured zebra has to rely on the strength, not only of the dazzle and of the group, but on the strength of each individual zebra. And so us as zebras and as people with chronic illnesses and us just as people and souls in general, we have to rely on the strength of others. And especially for those of us with chronic illness, that's hard because we have been introduced to medical gaslighting and judgment and eye rolls. And it's so incredibly hard to allow ourselves to rely on the strength of others. It's just so much easier to push it down and rely on us. But we can't do it with us. We have to rely on the strength of others. And we have to give others our strength when we have it. Because if it wasn't for the strength of others, I wouldn't be here talking to you. I wouldn't have had my mom, who has taken me and my son in since my shoulder surgery because I can't carry him. I wouldn't have that super hot guy over there who I've been bragging on all night because here I am diagnosed with Ehlers-Danlos, and the first thing he does is watch lectures and tries to learn more about it and is like, how can I help? How can we start a nonprofit? What can I do? Not what can you do as somebody with Ehlers-Danlos, what can I do as a supporter? And that's what we need. We need more supporters. We need more people like Dr. Norris, who is like, we're going to figure this out. We need more people to rely on strength, and we need more people to give our strength to. And so as I close and finish talking, and you guys are like, this girl's been up here talking about zebras for 20 minutes. I'm just going to say that I'm here for each and every one of you to give my strength when I can, and hopefully take some strength when I can't. So thank you so much for letting me talk and hopefully inspire. Yeah, thanks.
Kayla, that was amazing. Thank you so much. Thank you so much. And it's so true. We need to support each other. And we can be the change. If we make people see us, that's where things will start to change. And I know that's hard, but hang in there. So next we have Dr. Joseph Eichinger. He is a dual board certified orthopedic and sports medicine surgeon with a subspecialty focus on shoulder and elbow surgery. He is a professor of orthopedic surgery at MUSC and team doctor for the Charleston River Dogs. A retired U.S. Army colonel with multiple deployments, he is formerly the chief of orthopedic surgery at Madigan Army Medical Center in Tacoma, Washington, and at Womack Army Medical Center at Fort Bragg, North Carolina. He received his undergraduate degree from the U.S. Military Academy at West Point and his MD degree from from Temple University School of Medicine in Philadelphia, Pennsylvania, and completed his orthopedic surgery residency at Madigan Army Medical Center and the Harvard Shoulder and Elbow Surgery Fellowship in Boston. He's a fellow in the American Academy of Orthopedic Surgeons and a member of the prestigious American Orthopedic Association, to which fewer than 5% of all orthopedic surgeons belong. He is on the editorial board for the Journal of Arthroscopy and Related Research and is a reviewer for the Journal of Shoulder and Elbow Surgery, American Journal of Sports Medicine, Clinical Orthopedics and Clinical Research, Orthopedics, Journal of the American Academy of Orthopedic Surgeons, and Military Medicine. Dr. Eichinger is active in research and has presented research and lectured at numerous national meetings. He has also served as the shoulder chairman for the 2016 and 2017 fall courses and served as the shoulder chairman for the 2018 annual meeting for the Arthroscopy Association of North America. He has published over 64 peer-reviewed scientific articles.
USB-C adapter.
So, thank you so much for joining us tonight, Dr. Eichinger.
Thank you very much. You guys see me okay on my stand here?
Thank you.
So thank you for that kind of introduction. Kyla, thank you for all of your comments. That was wonderful. You talked about zebras. In the medical profession, zebras are the things that you don't think of, the things that are not common. And what we're finding is that problems like Ehlers-Danlos manifest itself pretty commonly, and I think it's we're seeing it more frequently, I think, than we ever have in the past, which is a good thing. And I think an organization like this is fantastic because it sheds some light on it, and the fact that there's a support group like this, I think, is tremendous. I'll talk a little bit about some of the biases that even orthopedics has traditionally toward patients with Ehlers-Danlos, and maybe how that's been a barrier in the past to them getting the kinds of treatment they need. So hopefully in this talk what we'll do is I'll talk a little bit about Ehlers-Danlos syndrome, how does it affect the musculoskeletal system, and how do we diagnose it, what are some of the methods that we've done, and maybe improving that, as well as new methods for treating it.
Dr. Norris offered to take anyone through the genetics lab tonight after the meeting if you're interested. So this is good. I'm getting to tell you before everybody turns and scoots out. So
You get to,
he's
you
around,
get to talk.
and you can find him at the end of the meeting and take it over to Cedar Genetics.
You like that?
The more pressing.
Yes, let's go.
And then finally, I'll show you a couple of case examples of a couple of cases. So what is Ehlers-Danlos syndrome? Most of you know this already. It's obviously a disorder that heavily relates to the musculoskeletal system. There's multiple subtypes, and obviously there's a bunch of research going on with Chip. He's probably cringing at my discussing genetic basis. but there's definitely a hypermobile type, and hopefully through some of the research that he and Courtney Jensmer are doing, will shed some more light on this. And I think that that's going to be super important. And hopefully what we can do is, once we understand maybe what a person's particular genetic component is, maybe that can help target some of the treatments, or at least give them some idea of what they can expect with their severity of disease, perhaps. And so I think that kind of research is going to be very important to do, and for us to help patients in the future. Obviously, it affects collagen. So collagen is sort of one of the soft tissue building blocks of the body, and specifically skin, ligaments, joints, the blood vessels, internal organs are all can be affected with this. The spectrum of severity that I see sometimes is real mild. You just see some minimal findings in this, and in some cases it's really severe and can be very difficult, and obviously can result in some cases things that can be life-threatening. Here's just some pictures. Obviously, many of you are familiar with these kinds of things, but this is some of the different ways that we can see it manifest from a physical standpoint. And one of the things that we look at, and one of the important diagnostic criteria that we use is this thing called Batten score. And this was a study that was actually done a number of years ago, almost 50 years ago, where they were looking at African kids, and they were seeing the slew of this population that had all these hypermobile issues. And so they came up with this Batten score as a way to sort of categorize and distinguish severity. This is something that has sort of persisted for us, and so you get a score out of 9. And so for the things like the thumb to the forearm, the elbow hyperextension, those would be 1 point for each side, and then your ability to place your hands on the floor with your knees fully extended would be the 9th score. And so whenever we would see some of the 9 out of 9, you would sort of automatically say, hey, by definition, you've got Ehlers-Danlos. And so that's something that we still use today to help us sort of figure out how severe this is for patients from a musculoskeletal standpoint. Obviously, we see it in a younger population. We'll see it in kids. Sometimes that doesn't necessarily mean EDS. Kids in general are a lot more flexible than adults. We do see that in a lot of cases the symptoms seem to sort of subside over time with age, but that's not necessarily the case. Sometimes these can persist, and sometimes when you've had this problem over time, it's maybe not instability, but then it becomes an arthritis problem. So it's something that doesn't necessarily go away with just being a child. We see it mostly in women, but there are a number of men, as Susan can attest to, that do have this problem. And why is it that women have it more severely than men? I think that's a question that probably needs to be delved into with some of the research. But certainly we see more women with men that at least have more symptoms with this. The prevalence of it, I don't think we fully know. Like I said, there's a sort of this spectrum where you get people that have real mild, some people that are more symptomatic. But I think it's a lot more common than people actually think. And this one study that we saw out of Wales was about 1 in 500 people, and that's probably underestimating. probably. So, how does it manifest from an orthopedic standpoint? I mean, we see a lot of patients that have sprains or dislocations or even what we call subluxation events, so they get a partial dislocation, but it doesn't stay out. Dislocations where it goes out completely and maybe stays out for a longer period of time. They're more prone to have things like tendonitis, muscle spasm, ligament tears, and the collagen just isn't, it's compromised in a way. And then obviously if you have it for a long period of time, arthritis, and in some cases, some people think there may be an increase in incident fractures. So why is the shoulder a problem? Why is this difficult? Well, it's a problem for a lot of people, even people without instability. Without EDS. And the shoulder is an interesting joint. It really helps us function. It allows us, our shoulder does, to put our hand really anywhere in space. And the joint most responsible for that is the shoulder. It's that incredible flexibility and range of motion, but it comes at a cost. The shoulder joint, because it's sort of like a golf ball on a tee where the ball is bigger than the socket, affording us that instability, it is more prone to having dislocation events. And so if you already have soft tissue that potentially is compromised or is prone to having problems, and you put that into a joint that already is by definition sort of unstable to begin with, that's why this joint can be affected quite often. So the shoulder anatomy, like I said, it's sort of like a golf ball on a tee. It's unlike the hip, for example. The hip is more like a grapefruit in a bowl. It's hard to get that out of the socket. The shoulder is not. It's easy to get it out of the socket. And so there's certain structures that we look at with this. We've obviously got what we call the static structures, things that don't really move, like the labrum, which is very important, the biceps tendon anchor, and then the capsule, which has the ligaments. And then we talked about the dynamic part of it, and that's the rotator cuff. The rotator cuff is essential for helping keep the ball centered on the socket. So shoulder instability comes in a lot of different forms and flavors. We see a lot of patients, especially from the sporting side, football players, contact athletes, that get traumatic dislocations. And the vast majority of these are anterior dislocations, so it's a single traumatic event where they dislocate their shoulder. You can also have these posterior dislocations. Those are more attritional. We see sometimes those in football players, people with their arms fully extended. They're not as often a traumatic, but more of an attritional athletic event. And then you have the sort of the more multi-directional, the EDS adaptation. Now, most of the time with EDS, usually they usually go in one direction. It's either out the back or out the front, or sometimes they can go straight down. And so usually there's a dominant dislocation. When we're figuring out treatment, we try to figure that out if we can. I'll show you some examples of that. So the patient history, sometimes it can be a little bit difficult to figure out. Patients will come in and tell you they have pain, but they don't necessarily give you a history of having a fall or some sort of a traumatic event. And pain is the thing that really brings them in. Usually the pain's in the back of the shoulder, but sometimes it's really vague. Sometimes people can't tell you where it's coming from. And sometimes they just have a hard time telling you what's wrong. Just my shoulder hurts. There's something going on with it. Clicking and popping oftentimes are something that we'll see with this, and that's sometimes maybe there's a torn labrum. As the humeral head slides back and forth over that labrum, you get that characteristic popping or clicking. And sometimes patients will come in and they'll actually they can pop out their shoulder for you. We call it an auto jerk or a self-jerk test where they can pop their shoulder out, and as they move it back in, it pops into place. And so sometimes they'll present to you like that, and you know right away, hey, that's obviously instability. So this is going to that idea of where orthopedics, when I was first starting out, learning about shoulder as a resident, historically, for this type of a problem, somebody that's got multi-directional instability, they go out the front, they go out the back, they just seem to be all over the place. Surgery doesn't work on those patients. You can't operate on them. And patients with this problem are crazy. People with voluntary shoulder instability, it's a psychiatric condition. You shouldn't operate on these patients. So that was sort of the dogmatic approach when I was first training, which was difficult because I think that because there wasn't great surgical options for this, and it was a difficult problem, it was kind of easy for surgeons maybe to sort of have that bias to say, well, it's all in your head. You gotta figure out a way to treat this on your own. And so that was really tough. And I think a lot of patients probably got undertreated for that. And I think it's groups like this, and it's sort of some of the research we're doing where, in reality, there are good treatments for it. And whenever there's the ability to tell a patient about a group like this, or you've got excellent therapists who specialize in this, that's very, very helpful. But the idea that physical therapy is the only treatment that historically sometimes we would think about this condition is not true. There are options for this, and I think we're getting better at it. Hopefully, I'll share some of that with you tonight. So historically, one of the other problems was the physical exam. You bring these patients in, and you talked about your therapist hurting you. I think sometimes doing the exam and seeing these patients, you actually put them in pain and hurt them. And you realize, or I realized very early on, is it has to be a very gentle examination. You have to be able to allow the patient to tell you what's going on. And if you're laying them on the table and you're getting on top of them and forcefully manipulating their shoulder, you're not going to get anywhere. And so what I've learned to do with these, and not just even people with Ehlers-Danlos, but really anybody with shoulder disability. If you've got an unstable shoulder, you've got to be gentle with that person. You can't dislocate them in clinic. That's not good. So here's some examples. Yeah. So here's some of the examples of tests. You can see how these traditional tests, and we'll still do some of these tests, and the principles behind these tests are important, but you can see how there's this manipulation that we're doing. Both hands on the patient. Here's another one. That doesn't look very comfortable, does it? Where you're just pushing your hands in. And these are still tests that are taught today, and that in some cases will do, but you have to realize that these can be very painful for patients. And this is one of the things when I've given talks is trying to make surgeons realize that there's a different way to do these testing. And I think one of the things is really understanding the biomechanics of how, especially posterior shoulder instability, which is oftentimes the problem that we'll see in patients with Ehlers-Danlos, and understanding the biomechanics and learning that. So here's one of the tests that we'll do where we have the patient bring their arm across their body. And what this is doing, as you can see on the right, is that you're creating a shear force. So instead of having the humeral head centered on the socket, now you're making it basically 90 degrees to the socket. So you're introducing this shear force, and it tends to want to make the shoulders slide out the back. And then by rotating the thumb like this, what you're doing is you're turning off the back of the rotator cuff, the infraspinatus. I know I'm throwing a lot of anatomy in here, but that's your dynamic stabilizer. I talked about the static stabilizers like the labrum and the capsule. If those are compromised, then the only thing you got left is the rotator cuff. So then you turn off that back rotator cuff and you have them turn their thumb this way. Now there's nothing holding them out. And so what we'll do is we'll let them go into that position and ask them, hey, how does that feel? What's happening to you? And then you can just put your hand above it and apply a little bit of gentle pressure as they come up against you. And that helps you figure this out. That's the important test. And then you can check the same thing with the arm now pointed directly at the socket so it's not inducing a shear stress. You turn on the rotator cuff again and then test them again and ask them, hey, does that feel better or not? Do you feel more stable in that position? So you can actually determine a lot of this without that forceful manipulation. Now here's an example of a patient with EDS. And you can see we're getting ready to do surgery, so they're asleep, so I'm not putting it to pain. But this is a great example of doing this load and shift test, and you can see they go out the back and out the front. And so really, pretty unstable shoulder. But that's what we try to do. We want to figure out what is the direction that they have their primary issue in. And then we want to confirm it on the imaging, our clinical exam, the history that we take, and then once we're in the operating room, we do the same things to make sure that we address it. Now, imaging is a really important part of this. We start with plain x-rays. And you can see in this x-ray on the left here where the shoulder is just not centered on the socket. And so right here is a clue that this is someone with Ehlers-Danlos and really pretty severe. They've actually had multiple surgeries prior to this, and they're still having some instability. And you can see on the right, this is part of the reason why it's so painful. When you have those subluxation dislocation events, the cartilage is experiencing that shear stress, and the capsule's getting stretched out, and it's painful when when these things occur. MRI is a really important modality for this, and we usually like to get an MRA. MRA stands for magnetic resonance arthrogram as opposed to magnetic resonance image. And the difference is the radiologist puts a little bit of contrast in your shoulder, and then they put you in the MRI scanner. And so you can see that can allow you to identify labral tears, labral separations. And so those are the studies we like to get for this. And one of the studies we did here at this institution was, and this is good, this is another reason I didn't talk about earlier, why it sometimes is difficult, is sometimes patients will get an MRI and the radiologist will say it's normal. Okay, but the patients, we can dislocate them in clinic. They're having pain, so how could they have a normal MRI? And sometimes it's really difficult, especially if you've got a younger patient, right? They're a teenager with this, they're there with mom and dad, and you're talking to them, and the radiologist, said it's a normal MRI. Well, that's a difficult conversation for me to have. I think your child needs surgery. But wait a second, the radiologist said the MRI is normal. How there's a disconnect here. You're telling me it's not normal, but the radiologist said that it isn't normal. And so that was a challenge. So that was one of the reasons we did this study. And what we found is that if you look closely at this picture, it's a little bit small here, but this is a patient in the MRI scanner. And if you compare having the palm up versus the palm down, and it shows A corresponds to A, B corresponds to B, you can see how the blue, which is the capsular area in the back, changes. And what we found is that if you get an MRI with the hand up or an external rotation, it allows us to get better measurements of the size of that capsule. And we've been able to determine what size or length of that capsule corresponds to its stability. And so that has been really helpful for us to sort of identify patients that do have pathology, that do have these enlarged capsules and would benefit from surgery. So that's actually a paper we studied, or we published in 2021 in the Journal of Arthroscopy. So, nevertheless, I know we're talking a lot about surgery here. The mainstay treatment for the vast majority of these is physical therapy, and what we call proprioceptive control. So, kind of what we're talking about now, and understanding different positions that may put you in a position of instability, and then also strengthening that dynamic stabilizer, so the rotator cuff, making sure that rotator cuff is as strong as we can get it to keep the shoulder stable. So what about surgical treatment? Well, historically, if you were going to do surgery on someone with multidirectional instability, the primary original treatment was to do what's called an open capsular shift. And those are those three pictures you see on the left there. And basically you do an open approach to the front of the shoulder, classic deltopectoral approach. You go between the deltoid and the pectoralis, and then you take off the front rotator cuff and it brings you down to that capsule in the front. And so this is one technique. This is sort of one of the classic techniques where you cut the capsule horizontally, and then you do this so-called cancel the best, and you basically just tighten the shoulder. And that was considered sort of the best way to treat this. When arthroscopy came out, and arthroscopy started to be used for things like shoulder instability, people were saying, well, hey, can we treat multidirectional instability with shoulder arthroscopy? And some of the early studies, like this paper here, said, nope, you still got to do an open capsular shift. It doesn't work as well. But what we found is that with better arthroscopic techniques, you can have just as good of an outcome doing an arthroscopic capsular shift. The nice thing is it's not a big open invasive surgery. You're just using small little poke holes to achieve the same goal. And so here's kind of some examples of what this looks like. So this is on the left here. You can see the blue star is basically the humeral head. Here's the socket. Here you can see the labrum is detached from the socket, and then we're using these things called suture anchors, which are you can see some of those anchors going in on the video on the right that we use then to suture the labrum back to the suture the labrum back to the glenoid. And we use these things, these little suture passers. You can see that we shuttle the sutures, and we're not only just bringing the labrum up, but we're also taking a bite of the capsule. And And so we're trying to reduce that volume. You saw on that one view where the volume of the capsule is really enlarged. We're trying to make that a little bit smaller, and that's what provides the stability of the shoulder. And so the vast majority of these work very, very well for patients and are excellent in terms of the outcome. Now, sometimes we see patients that are difficult, right? So patients that we're seeing for the first time that haven't had surgery before, they don't have any, particularly difficult problems. For the most part, we can treat them with a standard arthroscopic capsulorrhaphy, Bankart repair, basically tightening the shoulder. Sometimes I see patients with difficult problems, and so for some of you who are maybe listening or even some of you here in the audience who've been through this, some of this a couple of these patients may resonate with you. This is a woman that I saw a number of years ago who her husband was in the military. This is actually a woman I took care of when I was still on active duty. And she had Ehlers-Danlos. She knew about it. She had the diagnosis. It wasn't a mystery. She'd had a couple of prior shoulder arthroscopies in high school. She had 2 apiece. They worked great for the time that they were working. But unfortunately, she just loosened up again. And they were both the surgery was done by an excellent surgeon. It wasn't durable. It just didn't last for her. And she had a child, and this is sometimes we'll see this where people will have Ehlers-Danlos and they have a baby, and with that relaxin that gets released, I think sometimes that can tip you over the edge a little bit. So I think that's what happened with her, and both of her shoulders just completely got unstable on her, and so she was super disabled with this, and it was a really difficult problem. She couldn't lift her children. Her husband was deployed. She was by herself. She was from the East Coast, and she was living on the West Coast. And it was a real difficult time for her. And her shoulder would go out, and she went to the ER. It seemed like every other night. And she got to know all the residents. She got to the ER so many times, and so it was a really difficult problem. And I was trying to figure out, okay, we're going to do the same surgery again. And I think one of the things that can be a challenge is if you have a surgery, a stabilization procedure, and it doesn't work, and you've got to have another one and another one. At some point, they stop working, and there's a decline in benefit over time. So that's why it's obviously very important to get it right the first time. Do a really good surgery the first time so you don't get to this spot. But sometimes this can happen, and I think this is where some of the research is important, because sometimes patients, even with a really well done surgery, may not last for them. So I think having the understanding, or maybe being able to understand that phenotype and know who those patients are, it's not very many, but there are a certain number that really don't necessarily respond to surgery. The collagen just won't hold. Her rotator cuff worked great. She actually had pretty good range of motion, but clearly was unstable. You can see her on her x-rays. She was starting to come out. And even on her MRI here, you can see her humeral head is just sitting out the back. It's not centered on the glenoid, and that's a recipe for pain and dysfunction. So it's really a primary instability problem for her. So there's another example of it. So what are we going to do for her? Well, because she had these things, what I ended up doing was, and I took out the surgical picture, I didn't want to scare anybody. But I ended up taking allograft tissue from a cadaver and creating new posterior capsules for her. And this was I presented her a case a couple of years ago. So we ended up doing this on both shoulders. We did them consecutively, 6 months apart. And this is her 2-year follow-up. She was kind enough to send this video, and she was doing fantastic. So this worked really well for her, and hopefully it will continue to be durable. So sometimes you have to think outside the box. You have to do some alternative techniques with some of these things. Here's another patient, again, really difficult, and she was in just really tough circumstances. She got diagnosed with a nasty cancer. It just had a baby, and had already had multiple prior operations on both shoulders, and now it was just both of them were dislocating. And I think I did a total of 2 surgeries on one side and 3 on the other. And all of them, over a period of about 3 years, all got loose. And she'd already had 4 or 5 on each shoulder by the time I saw her. And so just a really difficult problem. And in the past, when I had these patients, what we would do is we'd do a fusion. So we basically would take the humeral bone and fuse it to the glenoid, so it just can't dislocate anymore, because you kind of run out of options. So I presented, hey, here's your options, because I don't think doing more instability surgery is going to work. It's just not going to work. And so it was basically doing a shoulder arthrodesis, or I gave her the option of doing a shoulder replacement. And I'd never done a shoulder replacement, or at least what we call reverse total shoulder. It's someone this young. I mean, prior to this, the youngest patient I'd done this in was 38. And here she is 26. But she didn't want to lose that motion in the shoulder. And I made her promise me that she wasn't going to lift anything heavy. She was going to make these things last for 70 years. So since this was, I just have her left shoulder. We recently did the right shoulder. And you can see here, her problem was she would go out the front and straight down. I mean, there was just no way to really keep her in anymore with any sort of soft tissue. So this is the reverse total shoulder that you're seeing here on the right. It's called the reverse because the ball and socket are flipped with one another, and it provides some additional stability. So even though she has an intact rotator cuff, we would use the reverse in this setting just because it helps keep the ball centered on the socket. So that's what she's got in right now, and actually is doing really, really well with that. So with that, I will open it up to questions. Yes.
There are a couple online. So there was a question, can EDS affect the spine and lead to kyphosis?
Yes, for sure. The EDS can certainly affect the spine. That is not, obviously my area of expertise, but certainly that can be a problem that can affect the spine. And I know some of the folks in here have experienced that. One of the difficult ones can be, atlantoaxial instability. But I think it can affect really the entire spine.
Another, if you will.
Yeah, go ahead. Go ahead.
Can shoulder instability in EDS cause neuropathic pain, so pain shooting down the arm following the nerves?
Absolutely, absolutely. So when you dislocate like that, the brachial plexus gets stretched. And so it's very common. That's one of the pain complaints that people can have is symptoms that go down into the hand, for sure.
Do you find that EDS patients who have the surgery on one side often need it on the other side?
It's a great question. Yes, I think we see that quite often. One thing that's interesting, and as you're asking these questions, I'm thinking about all these research that we can do because I don't know the true answer to that, and that would be a great thing to look at to study is how often do we do bilateral shoulders. One thing that's interesting, and maybe that's something we could ask patients that have the surgery, was that I feel like sometimes when they do therapy, on their operative shoulder, sometimes they do the therapy on the other side, and they sort of in the process of learning how to recover from their operative side, they figure out how to keep their other shoulder in. And so, I don't know, Susan, what do you think about that? Is that something you've seen?
So I live with that.
Yeah.
So I was, 30 years ago, actually, this month, I had an anterior modified capsular shift and rowing crew at Temple. And so over a period of 5 years, I just more frequently dislocated, and then my left side started dislocating. And after I had my right side operated on, my left side really stopped dislocating. It's still subluxed, but not. Yeah, and I see the same thing with my patients.
What do you attribute that to? Do you think it's the therapy, and that they sort of learn how to rehab their own shoulder? I mean, why is that?
I think, like in my case, it was I was right side dominant. That's what was dislocating. So I was leaning more to my left to help because my right was dislocating. And then I think after surgery, this became, so strong that I kind of started using my right arm more and not relying so much on my left.
Gotcha.
So yeah, I kind of, I just had hand surgery, and actually when I went to put my shirt on because I had a nerve block, I dislocated on my left. So we'll see what happens. with my patients, it just depends how bad, you know, they are. But yeah, I kind of see the same thing, or at least it buys time for a while. Let's put it that way. So.
If you fuse someone's shoulder, how much range of motion are they left with?
So believe it or not, a lot of times patients have unbelievable range of motion. So I actually did a fusion on a woman in her early 30s on both sides. You know, this was before, you know, doing the reverse. And she could get her arms up like this and come down here. I mean, it was amazing. If she had young children, she could lift them up. And part of it is all of your motion then comes from your scapular thoracic joint. So your ball and socket joint goes away. Now it's just your scapular thoracic joint. So if you have really good scapular thoracic motion, you can actually be quite functional.
I'm sure going into the surgery, you want every surgery to be successful. Are there any sort of predictors in people with Ehlers-Danlos syndrome that would determine the probability that a surgery would be successful versus one that wouldn't?
I think if you're doing it in a revision setting, you know, you're always concerned about that. And one of the reasons that, you know, I talk to the residents about this, before you go into an operation, especially if somebody, whether it's you or somebody else has done a procedure, you have to really understand why. So what went wrong with that other procedure, because you don't want to repeat the mistakes. And so you really have to, no matter what the operation is. And so one of the things you look at is, okay, how well was the surgery done? You know, how many anchors got put in? Where were they put in? That sort of thing. How did the rehab go? You know, what went on? And so I think, you know, sometimes you can tell maybe they didn't get the best operation. And so if you just do a really good operation the second time, they're going to be fine. But like I was talking about earlier, I think there is a subset of patients that the surgery just doesn't work as well. And you know, I think that it's a pretty small percentage of patients, and that's why I'm really interested in some of the work that Chip's lab is doing, because I think it's important to, if you identify somebody that has Ehlers-Danlos and they're sort of going to have surgery, they're going to have some sort of a procedure, if we can identify those phenotypes with those patients that, you know, are going to have potentially a worse outcome, that would be important to let them know. And that's important for the surgeon to know too, so you can counsel that patient. You know, in some cases, some patients do really well and they go back to doing whatever they want and life's good. And in other patients, you know, maybe you don't want to, you know, you want to caution them about doing X, Y, and Z. You know, if they're doing something that's really physical, or they want to do some sort of activity that has a higher risk to it in terms of having another shoulder dislocation, you know, maybe you want to counsel them not to maybe participate in that. And so having that kind of information up front, I think would be helpful. I see a patient that comes in, I say, oh boy, they're not going to do well. They're going to fail surgery. I don't really see that per se. I mean, I've seen patients that have profound instability that we do surgery on, and they do fantastic, and it's durable. So I don't even think it's necessarily patients that have really bad instability, really ugly looking MRIs. That's not necessarily the case.
I was going to say, in the same thing with what I see in my clinic, it's so hard to understand. I mean, really, you're just listening to history to know that this patient's going to do well versus this patient. It's almost the spectrum of some people are just really, really fragile, and other people will do well, you know, with the surgery. Other patients, it's just this constant, repetitive.
And that's not limited to the Ehlers-Danlos population. So there's a lot of research that's coming out now where there's this idea of resiliency. So, you know, how quickly do you bounce back from injury? How quickly do you bounce back from having an issue? And we found that multiple things. So it's traumatic instability in the military. People that are higher resilience, they do better. Patients that are undergoing total shoulder, which is typically an older population, 65 plus, if they're more resilient, they have better outcomes. That's an independent finding. So, you know, there's ways to build resiliency, and if patients have a group like this to sort of learn from and be a part of, I think that helps to build things like resiliency. You know, if you go, oh, hey, I see these patients, they've been through surgery, they've been through this problem, they've had this issue, and I see where they are. I've got questions about, you know, what I'm going to experience. I think a group like this is very helpful. But resiliency, definitely. And people have tried, I think, or they're trying to look at now, like how do you build resiliency in a patient so that they will have a better outcome, whether it's shoulder instability with someone with, you know, Ehlers-Danlos, or if it's, you know, somebody undergoing a total knee arthroplasty or anything, or some sort of spine operation. Patients that are more resilient do better. And I don't think we know as a profession how to optimize resiliency, but I know that that's an area of research.
I was just going to ask about a lot of patients that you showed were very young. Do you tend to see, if patients are going to present with problems that require surgery, do they tend to present younger? Or is that, do you have older patients with EDS that are presenting for the first time?
No, I do see older patients with EDS, and I kind of see them in a couple of different ways. It's sometimes it's patients that have always had sort of instability, and sometimes, you know, like we talked about the pregnancy, you know, your body gets exposed to a big dose of that relaxant. You were kind of doing okay, and now that happens, and it's like, you know, now you're really, really unstable. And so I think sometimes patients that are older are just kind of teetering on the edge of sort of managing, and something happens and they go over the edge. And you know, it's less common to see patients in their 40s, 50s, and 60s, but I have seen patients that with Ehlers-Danlos at that age that have now instability that's more symptomatic. Other patients that I see, they have arthritis. So now they have completely worn out shoulder, and they've got no cartilage left because this has gone on for so long, and so they're a little bit different in the sense that they, you know, now shoulder replacement as opposed to doing something instability wise. And they'll tell me the stories like, yeah, kind of the same. You know, I could do all these tricks when I was younger, but now my shoulders just hurt all the time. And they had this period of time where it was relatively quiescent for them. You know, they couldn't do anything, you know, really major physically, but they weren't in pain. They were living lives. They were doing fine. But now the sort of all those episodes of the shoulders dislocating or subluxating, the cartilage has become damaged, and now they have symptomatic arthritis as a result.
EDS comes as such a package with cell issues and all the other things. Oh my gosh, me and my daughter always think the one same night. I noticed we took drinks at the same time. But anyway, what do you do to prepare for surgery with all of the other factors that come into play that could affect?
No, it's a great. Well, one of the issues is as oftentimes patients with EDS have multiple things going on. It's like, you know, they may have a atlantoaxial instability, or you know, some sort of a hip instability issue, and it's like, which one do you do? You know, do you stabilize their shoulder first, or should they go get their spine surgery first? I mean, and so it can be really difficult to try to sort these things out. It's something that I've had a conversation multiple times with Susan, and she struggles with that too. And usually, from my perspective, what I tell people are, you know, what's the worst thing? What's the most painful issue? And start with that. But you know, obviously, you know, spine surgery or people having neurologic issues, I mean, that probably trumps anything else. But it can be a challenge to just, you know, decide, you know, what do we work on, what do we do here? Yeah. Yes.
Mine specifically, like, does if a patient has EDS also has mast cell, does mast cell also have an impact on surgery? How that would go?
It hasn't had a huge impact in terms of doing shoulder arthroscopy and doing these particular procedures. I think we've had to, the anesthesiologists have had, sometimes in some cases have to do different things in terms of anesthesia to manage it, depending on, you know, what's going on with that individual patient. But from a surgical perspective of doing the surgery, it hasn't that particular factor hasn't been a huge factor. Yes.
There are a lot of questions online, so. One is, what's most important to look for, this actually might be a question for Susan, in a qualified PT for EDS specifically for shoulder instability or tears. They're having a hard time finding a single PT that's literate in EDS and hypermobility.
All we got is Susan. I just call Susan up.
Gentle, somebody who's going to be gentle and not over push, somebody that's not going to push past normal range of motion because we don't have normal range of motion, and then baby steps, you know, take it slow, start with isometrics and slowly build. But the biggest thing I'm going to say, and all of my patients in this room know this, posture first, alignment first, and it has to come. I know you're treating a shoulder, but you've got to address alignment in an EDS person from the foundation, from the ground up, from the pelvis, to get that proper alignment to be able to functionally rehab a shoulder. So just somebody who understands this. It's hard. Yeah.
Yeah, you know, in the medical profession, you know, a lot of us are super subspecialized. Like, you know, I specialize in shoulder and elbow. And so we kind of all work in these little silos where, you know, we just think about our little piece here. And, you know, you have to look at it from a global perspective. And so I think having a therapist who kind of can work on multiple things is probably pretty wise. Because, you know, it's more than just the shoulder. It's more than just the back. It's multiple things typically.
So there's also a couple of questions that are sort of similar. So could multidirectional instability cause severe scapular pain? And then there's also a question about, do you ever see instability in like the collarbone and the shoulder blade? And I assume they mean the ligaments there.
Yeah, it's a great question. So it says it's a normal MRI, and it's really not. But part of it is just an educational piece. It's just like what I talked about before when I was a junior resident. I'm learning about shoulder, and you know, I'm being taught these things that aren't quite accurate. And you know, I think our profession is getting better at recognizing, you know, this problem. And you got to open up your mind and sort of listen to patients. And when there's a problem, you just have to dig a little deeper. So sometimes I think, for shoulder specifically, you got to go see someone who does a lot of shoulder, you know, who treats that on a regular basis. So there is a benefit to people having subspecialization because they're going to be more likely to be able to sort of hone in on certain problems.
What's the greatest need you have in order to keep advancing your work with Ehlers-Danlos patients? More people like you, better funding, more information, more studies?
I think, I think one thing that's really been helpful, I mean, over the last 2-3 years, it seems like, you know, I've collaborated with Susan quite a bit, and so seeing a lot of these patients has really been helpful. And I think, you know, for those of you, I think, in the room, especially in the room or listening, you know, when we send out those questionnaires about your function, those are super important. And fortunately, I do have some research funding to do that. So I've got a couple of full-time research assistants, and yeah, certainly that, you know, it's research sometimes is a fragile existence. You know, if you lose some funding, and you know, like during the pandemic, I lost two studies went offline, which is, you know, it's very stressful. And so I think the research funding piece is very important for this because you can't do this without having those types of assets. And because the only way you can advance this is through clinical research, and that's following patients. And you got to know how well they're doing. You got to follow them over the long term, and that requires effort. That requires having research assistants. And then the type of stuff that Chip is doing is super important. And you know, we have to collaborate on this sort of this you know, the bench to bedside research, if you will, where you know, we're doing things to try to identify certain phenotypes that may have implications in terms of how they respond to orthopedic procedures and things like that. But I think that those are the important things is being able to continue to see patients with Ehlers-Danlos and care for them. So I think having this institute start is huge. I mean, that's really important. So getting that off the ground and then continuing to collaborate, I think is important.
It's a pretty good question. How long do you recommend trying conservative care before getting the surgical consult?
It's a great question. I mean, I think and Susan probably has an opinion about this. For me, it's, you know, we usually send people to therapy, you know, for sort of 6-week blocks, if you will, 6 to 8 weeks. And I tell patients, you know, if you haven't made any improvement over a period of 6 to 8 weeks, where you've gone backwards or none of that treatment has really helped you at all, then we kind of consider that sort of a failure of treatment. And it depends, you know. I think a lot of times we err on the side of being conservative, and so we try to always treat patients with therapy first, and we hope that we're successful with that. And so we kind of teased it out. Sometimes, you know, we have to ask people, how many times do you actually go to therapy? Did you make all your appointments or not? And so, but typically it's, you know, 6 to 12 weeks. If they haven't made any changes, they haven't gotten better, that's sort of a time frame to me that they're not making improvements. What do you think, Susan? What's your take?
Yeah, about that. Sometimes it's longer. Sometimes we know sooner when just nothing, you know, anything that I do, and I really start at a low level. And if I'm just not getting anywhere in a few weeks, probably 3 weeks, and we're barely doing anything, then we kind of know. But typically, a good 6 to 8 weeks, that gives us a good idea. And sometimes it's just a little ounce of baby step, like the last patient I saw today, and I said, well, you know, what do you think? He's seen her, she has multi-directional instability, but she has other moving parts going on, and she said the shoulder's really a problem. And I said, well, what do you think? We've been working on it, but we've really been working on it at a low level. And she's like, oh my gosh, she's like, even just this little bit we're doing, I'm seeing improvement. So that, you know, that gives us hope that she will improve. She's got other things going on, so you have to kind of prioritize as well.
Thank you so very much. I appreciate all the questions. That was great to hear. And this organization, I think, is fantastic, and I think hopefully over the next few years we can make some additional advancements in understanding the treatment. So congratulations to all of you for participating in this and helping push forward. I hope that you know, this group results in a lot of patients getting a lot of answers to the questions and getting the treatment that they need. So thank you. I'm showing this where I did that posterior reconstruction. That really, you know, that patient really was a big game changer for me because, you know, she had sort of failed all the conventional treatments, and I was relatively early on in my practice. And I was just trying to figure out a way to help her out, and it really forced me to delve into the literature, really try to understand this disease and figure out how to help her. You know, how can we get her from going to the ER every other week? This is terrible. She's by herself with the kids. We need to figure out something that's going to work. And quite honestly, the literature is pretty lacking. You know, there's just a lack of understanding of it. And it goes back to some of that bias in our profession about patients you can't do anything for. So that's, I think that patient really got me, you know, sort of figuring this out or wanting to figure out better ways to treat patients like her. And it's been rewarding to see something like that so disabled.
Yeah. Well, I have to admire you for that. I'm very grateful for that also. Yeah, thank you so much. We always say, if you can't connect the issues, what do you do? And then connect the issues. Okay, so like I said, anybody who is interested in touring the genetics lab, Chip and Courtney are back there. They can take you over. June 2nd will be our next meeting. We're really excited about that, and I hope we can get as many people out as possible for Dr. Francomano, Dr. Claire Francomano, to come and give a lecture. And then the other thing, we have our United Night event. We've had it 2 times now, and it's been really great. It helps to benefit funding for the Bobby Jones Chiari Surrender Waiota Foundation. We'll probably be doing it on the Greenway again. We still have to confirm that with the Greenway. But we're planning most likely October 22nd. And it's just a couple hours where everybody comes, we enjoy each other. We have music, we have raffles, and get together. And then we do a 1-mile walk. It is optional. We make sure that the path is wheelchair friendly, and you create your team, your zebra team or whatever, and ask people to join your team and sponsor you or whatever, and raise funds for the Bobby Jones CSI. So we're excited. The people who have come in the past, we've had a really good time. And actually, Ray from the Charleston Stingrays came, and as long as they can get here, if they don't have conflict with their games, I know they're going to come again. So it's really fun. So I hope you all will keep in touch and plan to take part in that. Okay, so that wraps it up for the night. Thank you so much again, and please grab leftovers out there to come home. Okay. And thank you, Dorothy and Gary.
Well, thank